are other drugs being developed for p53, not really so much in AML yet, but APR-246.
Right, absolutely. So it does include a group of patients with AML, particularly the oligoleukemic, or what we used to call the RAPT. So APR-246 is a drug that binds to mutant p53, restoring the wild function of the protein. And originally it had been tested actually to resensitize ovarian cancer, for cisplatin, because that's part of the resistance there. We tested the drug preclinically originally, showing some additive effect with azacitidine, particularly if it was given just before azacitidine. Through the MDS consortium, we conducted the phase 1 and phase 2 studies. So those studies included MDS patients and oligoleukemic AML patients with p53 mutation. And obviously, again, we've been talking about p53 all the day, that those are the patients that have the worst outcome. I think you alluded that they do have some higher responses to azacitidine or decitabine up front, but they relapse shortly. The median survival is 4 to 6 months. So what we've seen with the APR-246 at this meeting, there were 2 presentations, one from the US part, the MDS Clinical Consortium, and one from our colleagues from the French group. Both included around 50 patients, all of them higher risk p53 mutant. And the response rates are in the range of around 80% overall responses. Again, this is combining MDS and the AML. Around 50% plus CR rates and around 17-18% marrow CR plus hematological improvement. Somewhere around 40 to 50% of the patients became NGS negative for the p53 mutation, and there is a subset that have like MRD status achieved. In the US study, at least around 19% to 19 patients were able to go to transplant, went to transplant with this. And the survival seems in the range of 1 year plus at this point. So it's very promising. This is already in a phase 3, actually, randomizing patients between azacitidine, APR-246. I think for me, the key there would be showing the durability of the response. And if it is, or it's, as you mentioned earlier, we are going to be able to take more patients with p53 to transplant. I think this is a very promising strategy.
But we're getting a couple of chinks in TP53's armor.
It's pretty exciting.
Hopefully slow and steady, yeah.
Dan, why don't you finish up this section, tell us about combinations with venetoclax, other than chemotherapy, more targeted agents.
Well, Naval presented some really nice data for venetoclax with the idasanutlin, which is has a complicated mechanism, but I think one of the exciting things is maybe its ability to target MCL1 indirectly, among other elements of the MDM2 pathway, and I think some very promising results in the relapsed refractory setting. And I think that's maybe a good lesson for us, that MCL1 is going to be a vital target in the post-venetoclax, or in the relapse setting, or in the post-venetoclax relapse setting. And I think lots of other opportunities there, been alluded to already here today with respect to FLT3 and other targeted therapies. So I think it's a pretty exciting opportunities.
Well, and I think that's what we've discussed today. I mean, not only a number of important drug approvals in the last couple of years, but a number of exciting new agents coming along very quickly. The challenge for all of us is to get back to work tomorrow to design the right clinical trials to show that these new agents truly have benefits for our patients, not only in improving survival, but we do need to look at quality of life as well for our older patients, but not forget that we can cure this disease with the tools we already have. This has been a great discussion. Thank you. On behalf of our panel, we hope you found this peer exchange discussion to be useful and informative.